Okay, this video is going to cover some important topics that I think we were limited on our class time, but I want to make sure that you have these topics kind of clear about how they are similar and yet different. So first, let's talk about what coronary artery disease is. This is just when there are deposits of lipids, if there's injury, inflammation, to the internal lining of an artery. And so a lot of times, if patients are symptomatic about that atherosclerosis of those coronary arteries, so heart arteries, that's where we'll start talking about coronary artery disease. Now in another video, we'll talk about PAD or peripheral artery disease. But here we're talking about these fatty deposits on those arteries of the heart. So coronary artery disease is progressive, starts with those fatty deposits. And so the goal is going to be, if we identify this early, to try to slow that progression to where they don't end up having some of the complications that we will talk about. Because the complications are actually where we get that unstable angina or MI. And that's what we think about when we talk about acute coronary syndrome, are unstable angina and myocardial infarction or MI. So when we first identify coronary artery disease, things that you will kind of hear in your assessment are family history. You want to be looking for any of those risk factors that we can modify, so things that might be dietary or exercise related versus those non-modifiable, because they can't change their genetics. You want to look for any chest pain, so angina, or any symptoms of poor perfusion that we have. Some of the lab tests that we will use to diagnose coronary artery disease are, we'll see an elevated C-reactive protein due to the inflammation. We'll see high cholesterol levels, elevated triglycerides, elevated LDL, elevated HDL, or low HDL when we want it to be high. And if they are diabetic, if they have a high fasting blood glucose, so they may not have been diagnosed with diabetes, so maybe they're pre-diabetes, but we're also seeing that patients that have a fasting blood glucose over 100 are at more risk for coronary artery disease. So with coronary artery disease, the priority interventions or actions are going to be to try to modify those risk factors that we can, so increase physical activity. We want to encourage optimal nutrition, stop smoking or use of tobacco products. And then again, if we see they've got that elevated fasting blood glucose, we're going to try to look at things we can do to reduce that. So improving exercise, improving diet. Again, we want to prevent this from progressing into unstable angina or MI or sudden cardiac death. So other things that you'll see that you might be doing education on, these are patients that you will see put on like the omega-3 fatty acids, maybe niacin, psyllium, soy. Those will help kind of decrease cholesterol. You'll see them placed on the statins to help bring down that lipid panel. Low dose aspirin, those types of drug therapies. Now, if it progresses on, that's where we start talking about our acute coronary syndrome. And so this is where these patients are going to be our unstable angina and MI. And then you'll also see patients that have had angina. It's considered chronic and ongoing. So those are patients that exhibit chest pain, but it's chronic. So what we always have to try to differentiate is, even with those chronic angina patients, they can go ahead and progress to an unstable angina or an MI, so it can get very kind of difficult to understand what's going on with those patients. Patients with coronary artery disease are at risk of ischemia when we don't have enough oxygen to meet the requirements of the myocardium, or that infarction where we actually get that death of tissue. So let's talk about angina a little bit. So angina is simply when we get chest pain, discomfort, pressure because the heart's not getting enough oxygen. Now, when this first initially happens, a lot of patients will think that they're having an MI. So they'll present with this chest pain, and then we'll have to do the whole diagnostic workup to really decide what's going on with this patient. So some of the things when you do assessments of chest pain, you want to ask questions, and you can kind of think about it like PRN. Is this pain precipitated, the P, by exertion or rest? Is it relieved with nitroglycerin? The pain lasts, less than 15 minutes. And are there any other symptoms? So the things that we'll teach our patients with angina, think ANGINA. A, stop activity. N is nitro. They can have 1 tab sublingual every 5 minutes times 3. And then they need to call 911 if it's not relieved. The G, give O2 by nasal cannula. So if they have home O2, they can use that. Or if they're in a healthcare setting, we want to give O2. Instruct when to report symptoms to the healthcare provider. N, the need for testing. So if we have ruled out MI, these are patients that we might see placed on Holter monitor, stress test, and then A, avoid smoking with these patients. Okay, so this is the different, what's considered like unstable angina, any new onset angina, the vasopastic, so that's when those arteries spasm and narrow. It used to be called Prinzmetal. Chest pain that's pre-infarction, so it might be a sign that a patient is getting ready to have an MI. And then we'll see that chest pain with patients that have an MI. And remember, there are those 2 different types of MI, the non-ST elevated MI or the STEMIs MI. So this just kind of overviews a little bit about kind of pathophysiology when we see them occurring with our patients. So MI is something that we need to address promptly. They're very serious because left untreated, it's going to cause ischemia and necrosis, so death of that cardiac tissue. And a lot of times it's related to thrombus blockage, so, a clot in a vessel, that if we can correct that, we can reestablish blood flow. So let's look at our assessment and cues that you want to have on your kind of, care plan. So history, if patients are have a lot of symptoms, we may not have a lot of historical or subjective data that we're able to collect. And so we're going to go on into some of our, rather than asking a lot of questions, we're going to really have to do a rapid focused physical assessment and then even maybe go into treatment. So we're going to look at our vitals, look for elevated heart rate, respiratory rate. We may see decreased or increased blood pressure, and decreased O2 sat would be a sign of poor perfusion. Really do a good assessment of the chest pain and try to find out, if it's relieved by rest, if it's positional, where it's located. Remember that sometimes we'll see atypical chest pain presentations. So sometimes women will exhibit with jaw or chin pain. So really ask lots of good questions regarding that pain or discomfort that they may be feeling. Look for any diaphoresis, skin color. They may be pale, ashen, or it may look very anxious. The labs that you're going to see we'll look for that 12 lead EKG to see if there's that ST elevation or T wave inversion. Those cardiac markers that we talked about, such as troponin, and these are patients that will very quickly want to do that coronary angiography to really establish that blood flow. And so a lot of times we're trying to get them to the cath lab quickly for treatment. Initially, these patients will be placed on bed rest with head of bed elevated. We want IV access. Think MONA with these patients, so morphine, IV, oxygen, nitro, and aspirin. So those are the 4 things that you'll see initially with this, along with those cardiac markers. And then we're trying to re-establish perfusion to the heart. And so these are patients that will end up with interventions through cardiac cath. We'll see thrombolytics. If we identify that they do have a clot, we want to try to get thrombolytics administered within 30 minutes of presentation, no more than 6 hours after symptoms started. And so if stenting is not available to work, these are patients that may end up with a CABG or coronary artery bypass graft with them. Complications that we want to always be aware of are things like dysrhythmias, heart failure, shock. This can be fatal if left, untreated or not diagnosed. So we want to be watching for that. With nurse, you want to closely monitor the pain, the vital signs, pulse ox, provide any anticoagulants, any medications. Some of our priority meds are going to be nitro. And again, think about after nitro, it's a vasodilator. We want to be looking for hypotension. So if we've elevated the head of bed, they develop hypotension, we need to decrease it. Morphine is going to be for chest pain not relieved by nitro. And again, look for respiratory depression, hypotension. You might see antiplatelets, anticoagulants, beta blockers, ACE inhibitors, thrombolytics, aspirin, even stool softeners used to prevent that Valsalva maneuver and vagal stimulation. Patients after an MI often will go through what we call cardiac rehab, to where they learn how to progress their exercise, learn about dietary changes, activities, avoiding stress. Patients may end up with home nitro, so we need to discuss the safe use of nitro with these patients as well. And this is just kind of, we've mentioned like with cardiac cath, the different types of interventions. So this talks about how the use of a balloon can be used to try to open up that artery. Stents are actually devices that are placed within that artery. So sometimes they'll do a balloon to open it up and then have to place a stent, to keep it open. Okay, hopefully this was helpful. If you have any other questions, let me know.